All right, good evening, everybody. Welcome to our new spot. I'd like to call to order the program and budget meeting for September 13th, 2017, and I'd like to start out by reading our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. Next item on the agenda is the adoption of the agenda. Need a motion to approve.
So move.
Support.
Motion by Joan, support from Susan. All in favor signify by saying aye.
Aye.
All opposed? All right, that passes. Next is hearing of the public. Anybody from the public wishing to address this body, you have 5 minutes. Anybody from the public? Going once? Going twice? All right, seeing none, we will close the hearing of the public. Next item, request to approve updated Jackson and Coker master agreement. John, you want to speak on this?
Yeah, sure. Thank you, Mr. Chairman. As you're aware, maybe 4 or 5 years ago, we were having a difficult time with psychiatrists and being able to retain and hold psychiatrists on our panel. And so we went out and we're pretty progressive relative to finding other psychiatric support. We entered into a contract of which the board approved 3 or 4 or 5 years ago that spoke to business with Jackson Coker. They're locum tenens, and their purpose is to hire professional supports staff. And so we've had a long-standing agreement with Jackson Coker for the purpose of psychiatry. We have 2 different psychiatrists who work with us under this agreement, and it has been able to aid us and able to continue to provide psychiatric services to our folks. The Jackson Coker asked for just a renewed agreement, and we put that before you. We ran it before Corporation Council at the county and asking for your approval of the renewed agreement.
Thank you, John. Members, I'd like to mention real quickly that if anybody has a question, please direct that question to John. And if John needs help answering it from staff, he will ask the staff member. So does anybody have any questions on this item?
I have a motion to approve.
Motion to approve from Kathy, second from Joan. Lou? Lou, can you make sure your mic's on too?
Yeah, I got to get used to the new system, but the print is really small, John. You know, it's a challenge. And I noticed that in several paragraphs, it mentions the word fees. What are the fees? How do they get charged if we pick up one of the psychiatrists under this contract, et cetera?
There's a number of fees that are into the contract. A number of them are not applicable to us. The ones that are directly our responsibility are the fees or the cost of purchasing the psychiatric services. So it's only related to the psychiatrists themselves. We don't purchase any finder's fees. We've not in a position where should we want to hire somebody and that we would have to pay for a fee relative to hiring a psychiatrist once they've already been employed by Jackson Coker. We pay them on an hourly fee based on the number of hours that the psychiatrist performs services. So same as our other psychiatrists as well too. We pay them only the number of hours that they actually perform the service.
We pay that to the psychiatrist or to the Jackson Coker, whatever the...
We pay that just an hourly fee to Jackson Coker, and Jackson Coker in turn pays the psychiatrist. Correct, yep.
Thank you.
Yep.
Linda?
So that makes them what's called a W-2 employer, where they pay the taxes and the Social Security, and we just pay whatever the fee is they're asking for that.
Their arrangements with their psychiatrists, I would suspect, are as you described. We pay them a straight administrative fee across the board for every hour that they deliver services to. And then the arrangements that they have with the psychiatrists are not something we're privy to.
Okay.
But I would suspect that they're doing as you described.
Thanks.
Any other questions? All right, seeing none, we have a motion and support on the floor. All in favor of approving signify by saying aye.
Aye.
All opposed? All right, it passes. Next is the Macomb County Community Mental Health IT Technology Plan, fiscal year 2017-2018.
Every year for the last quite a few years, we've been bringing before the Community Mental Health Board our technology plan, primarily for the purpose of the fact that the Information Technology Department and the director have a strategy on how we're going to continue with our software and our hardware technology over the course of the year. And as you're aware, through the Board of Commissioners, many of the departments have to come to the Board of Commissioners repeatedly for IT development and board approval for hardware, software purchases, and those types of things. We would be coming to the board very frequently, to the Community Mental Health Board, if we took that same tact. At the same point in time, I think it's important that the CMH board understands where we do plan to purchase hardware and software support. And so what we've done in the past is we've been able to present the entire strategic plan on IT software and hardware before the board, knowingly that we will procure and receive 3 bids for anything over $5,000. So if we wanted to buy a large piece of equipment, we will look at 3 bids and go with the best vendor, the lowest bid on that. But it's this our opportunity at this point in time for the director, for Bill Adragna on the left and Thomas on the right, who supports Bill. And I asked them to present the IT plan. Jim, Bill, you want to take care of that?
Yeah, so I'm Bill Adragna, for any that don't know me, and this is Thomas Cole. He's our systems administrator, I'm our chief information officer. The plans that we have turned in the past represented basically 2 separate things. Things that were ongoing costs that were going to recur every year, computer replacement strategies, software licensing, that sort of thing. And then once we built out that portion of the plan every year, we would then look at things that we think are due for an upgrade. And we would fill out the rest of that budget based on what things we could afford to upgrade and stay within a certain amount, and what things we thought could wait another year. This year it was Tom's idea when, in lieu of all the financial situation here, Tom came to me and presented that he felt we could forego this year of major upgrades because of the number of things we've purchased in the last couple of years, couple little items that sidetracked us this year. We didn't really fully implement all of the new technology. This will give us another year to implement the newest technology, get our disaster recovery site fully up and running, and we are backed up to our secondary location, Lou, and help out the organization financially. Now, we did include a couple of items in there that should we realize we have achieved more savings and have money to spend, we could then come back and present those items. 2 of the things being our phone system and our email system. But we could realistically go this year without them and help the organization.
Yeah, and just simply speaking briefly on those 2 systems, the mail system would represent an ongoing cost in every budget every year going forward as long as we do business. The phone system would be something that we paid for over the next 5 years and that we would own it in the end. So those are 2 things to consider if we were to be able to get something like that approved going forward. Obviously, we're saying these would be nice to haves, but not necessary given the way that we're maintaining those systems.
Yeah, and to further illustrate that point, the phone system is now 13 years old. So it's not going to go forever without a replacement, but we feel pretty confidently, short of maybe a minor equipment failure here or there, that we can get through the year without doing it this year.
All right, thank you. Questions? Sure. Brian, go ahead. Yes.
Okay. I got a couple questions. One is, how many projects are still going on? To go to John or go to them? Thank you.
Go ahead and ask Bill directly. He's at the podium there.
I'm sorry, clarify.
It says you have a few projects to finish up. How many do you have going on, and how long would it?
For example, implementing a full disaster recovery site, you go step at a time. We've got the data backing up to 15 Mile, and Tom can speak more detail for that if you want. We've got most of the servers backed up over there. We've now got to go complete the configuration. In the event of a failure of the main office, we could go to 15 Miles, spin up the new location, and administration would effectively move there into the community care center, the VDPS program. There would be enough places for us to sit enough people that we could continue the operation from there.
Yeah,
that's
and I believe at one point, Jim brought the work that we were doing with Abilita in front of you guys to get approval.
Yeah, that was
I'm
a
not
while
sure if it
ago.
was brought before this group or another group. We've been working on getting our billing down, and then that is required that we move phone services away from AT&T to another company, and so we're working on maintaining that. There's any number of other small projects that we're working on related to that. We have a very small staff, so we kind of just work within the constraints of that. But the primary thing is the disaster recovery, making sure that we have effective backups, both for disaster recovery purposes and also potential legal purposes. Those are the big things that we're working on, then maintaining the mail system and the phone system going forward in lieu of an upgrade.
And as an example of how things reorganize themselves, we had a failure of the voicemail server. We were planning on buying a new phone system next year because of the age of that voicemail server. But then we discovered that we could use the onboard voicemail from the Intertels. And while we were told in the beginning it wouldn't work for us, it seems to be working out pretty well for us, which is why we said, well, maybe we can wait another year before buying a phone system and continue. Tom's also modernizing the fax system, and that's another thing that's under development.
Then my second question is the phone system digital that we have now?
Yeah, it's voice over IP.
Okay.
So it's a modern phone system in a way, but it's
Yeah, I was nervous when you said
yeah.
13 years. I'm thinking,
Well,
digital came out maybe 10
We
years
bought
ago.
it in 2006.
Okay, thank you.
Susan?
Thank you. So just a couple quick questions. I know you mentioned that the backup site is 15 Mile. Is there a disaster recovery site that is outside of Southeast Michigan? Not for our staff to move to, but like a data recovery?
One of the things that we would like to look at going forward once we have these other systems established, such as the phone system, the mail system would be, so we would end up moving, it does say it on the technology plan, but we would end up moving to something like Office 365 or one of the Google services, and so that has its own set of backups, and then we can also keep our local backups. One thing that we would like to do after we establish these new systems is eventually look into getting something in the cloud, so to speak. So moving to offsite backups that in and of themselves are redundant and maintained by another company, which is fairly inexpensive at this point, but we want to make sure that we have our own systems established before.
Yeah, I mean, there's some security issues
And
with
if I
some of
could
that too that
clarify,
you'd have to address.
the primary business is the electronic medical record, which is Focus. That is in the cloud, and that is in duplicate locations within the country that are geographically diverse enough that if we lost all of Macomb County power, as long as our people can get out there and connect to the internet, they can connect to Focus.
Okay, yeah, and that was kind of what I was going for. I mean, we know from the recent hurricanes that we could have a whole state lose power almost.
Yeah, well, PCE's
so-
backup facility is located in maybe Chicago.
Okay, so.
I think it's further away than that.
Okay, and that's fine, and obviously I know you guys will be conscious of security of information and records. I'm sure that's all
Absolutely.
addressed. So I'm looking at some of the hardware equipment that you're buying. What are WISE terminals?
Essentially, most of our employees, as opposed to being on desktops, which there are some, or laptops or iPads, are on thin clients, and so they connect to centralized servers that exist both at our location and for disaster recovery purposes at 15 Mile, and then potentially in any further
Okay,
location that we
so
move out
it's-
to.
It's called remote desktop, and it means if I work on a WISE terminal, I can sit at any WISE terminal in the organization and log in
Okay.
to my same environment. I
So-
can even get to it from outside the network.
So why, I'm just looking at this because, I'm looking at it saying, okay, we've got desktops, we've got WISE terminals, we've got iPads, we've got laptops, so is there any thought or process about moving to something that is universal across all platforms? So, and I'm still a little bit in the dark ages, but nobody has a desktop where I work. It's, we all have at least laptops. Some of us still are moving to iPads, some of us are moving to different things, and I understand that that's a migration, but you seem to have old stuff to more current stuff, and I'm trying to figure out what the
Absolutely,
plan
and
is.
a lot of that is based upon simply what supervisors and such request, and we don't typically reach the numbers that are listed in that budget in terms of what we request in laptops, desktops. We just analyze trends, basically.
Okay.
And over time, we would eventually like, as you said, to move to a more centralized set of equipment, or eventually have people not on desktops at all and move into something more like a waste terminal, as
Right.
they're more inexpensive and more thoroughly covered by our backup practices.
Right. Yeah, I mean, it looks like it's quite a bit less.
Yes.
Per cost, per
Yes.
unit. So I
And-
would like to see us trying to move in that.
And back in 2002, I brought to this board, I know it was a lot of different members, the concept of a computer replacement strategy, because when I was brought in, all the computers were outdated in the whole place, and we had to make relatively massive purchases. So we implemented the computer replacement strategy with the goal of replacing a computer. We buy a desktop, for example, with a 3-year warranty. In the 4th year, we plan to be able to replace that computer, either if it has a hardware failure or on a schedule. So that way, the computers never get more than 1/4 of them being older computers. So we're always bringing in, and that's worked really well for us. And while we talked about not doing that this year, I think it's a mistake, because if we did, then half of our computers will be outdated, out of warranty, and we'd have no way to get the user back up and running.
Yeah, and it doesn't take long for some of the software to get away from the hardware. Like,
Yeah.
that disconnect happens pretty quick, and it's very difficult to Band-Aid. So, I mean, I'm not a technology person, I'm strictly a user, but I'm just saying. And then I just see, too, you're buying separate monitors and things like that, and I'm just thinking holistically, if there's a better plan and a strategy that you could smooth over time that might be more budget efficient in the long
Well,
run.
we're looking out, maybe a couple of years out, if the finances allow, to move to more cloud-based solutions that would give us a lot more capabilities about what people do when they do in the field, what people can work from where. It's the model that's in place now. We've been following it for a while, and the technology is moving to the point that we will be able to get there. But again, it's going to come down to what budget year can we decide to appropriate enough money, because most of those things come with a per user per month cost. So they all cost money to get to, whereas our solution doesn't cost the same kind of money. It's buy it once and use it until you need to replace it.
Yeah, and when we look at things like the email system and working with that company Abilita that I mentioned, what we're looking at going forward is demonstrating thoroughly documented the cost savings that we're affording from moving to these new services, and then using that possibly in the future to justify things such as the mail system upgrade. And that's
So
kind
it
of something
sounds
we
like
work
you're
out year
working on it, you're just not quite there yet, so
Yeah,
that's good.
yeah.
Okay, thank you.
All right, Linda?
Recently, 2 different people that, I communicate with at the agency have told me, I sent you an email, but you didn't get it because it didn't go out of our system. What is that?
We had 2 days, last week, Tom, where an email that shouldn't have broken our encryption engine, we use a Zix encryption engine to secure email while in transit, it tripped the Zix encryption in. The first time the guys got it working again, we hadn't expected, we never seen it before. The second time we engaged in Zix, and they went through the whole process. Then we engaged the user to make sure they cleaned up their address book. And then Zix did a health check to make sure we were within normal parameters, and Tom and Brent are bringing that server up to those health check standards. But it happened on 2 different days.
Yeah, and prior to that even, we had a complete failure of the server, and so we had to receive a new one. And so for that time being, we just informed people not to send
But that's
security.
just
When
a
things like that
glitch.
happen,
It's
it
not
makes it
it's
look
not
like
because
it
of the
happens.
age or
People will
because
say
of
it happens all the time, but
my age.
for us, the people monitoring this stuff, these guys are at home sending themselves email all the time on the weekend to make sure everything's working. And if it's not, they log in and try to figure out what's causing it.
Thanks.
Technology is always tricky.
Any other questions? Brian, go ahead.
Since you brought up the cloud, I've worked in the past in making changeover for electronics, and I realized that the hard drive or the mainframe that was going to sit in there was like, in this particular instance, it was $13,000. And I wanted it in-house and physically see it. And then they turned around and said, well, the cloud's $250. I said, go to the cloud. So do we have a lot of mainframes that we could put in the cloud? Is that savings still available, or has it gone up, the cloud's more
Well,
expensive?
We've already bought the equipment that we're using to virtualize most of our servers and our remote desktop for the users. So before we would, I don't think we'll ever replace it. We might need to add a little bit of memory to it before we go to the cloud-based systems as well. But those savings are equipment purchases versus ongoing savings. So we bought the virtualization hardware, we installed it, and now we don't pay. I mean, I know it takes a few years to pay the whole thing off, but once you go to the cloud, it's always a cost.
Yeah, and I want to make two separate points on that. As part of that, you look at something like that mail system, which is in essence moving to the cloud. And it does represent an additional cost, but there are savings that we have found in other areas to possibly cover an upgrade like that going forward. As I said, it's an ongoing cost. So there is cost savings, but the email system that we use right now is extremely inexpensive. It's just not very robust.
Okay.
But it does move the responsibility out of our hands.
All right.
In other areas, what the second point I wanted to make is that if we were looking at the cloud right now, we're simply looking at something like she mentioned, which is that we would want to have that as an additional place to keep our data. And so it would be an additional cost. We're not looking at cost-saving measures quite yet in terms of like moving most of our operations there.
And we follow all the latest trends in technology. When we think things are, we never buy at the cutting edge. When the people first out are jumping on board, we wait for the working edge. We wait till the bugs are worked out, the kinks are worked out, people like the service and are happy with it, because we can't afford to make a purchase and be wrong very often before we're out of money to spend.
Okay, thank you.
Any other questions? All right, seeing none, I need a motion to approve.
I think, didn't you
Support.
have a motion?
Did I have one? No,
I thought someone said a
I
motion.
thought it was on the last one. No, not
All
on
right,
this
I'll motion
one.
approve.
From Brian and
Support.
Joan. All right.
Thank you for your time.
Thank
Yes, thank you. All in favor signify by saying aye.
Aye.
All opposed? All right, moving on to receive and file. Michigan Department of Health and Human Services, Office of Recovery Oriented System of Care, State Targeted Response Allocations. John, did you want to speak to this?
Yeah, I'm going to turn that over to Randy. I think he's most equipped to be able to describe that for us.
Well, my question to you first off is, did you want me to walk you through this? Because you had a fairly lengthy document, but you've had a chance to read it, and then, or do you want to just have me answer questions? Okay, no preference?
Yep, no
then you get the
preference.
long version.
Just give us a brief summary and then we'll ask questions. How's that?
All right, fair enough. First off, what these dollars represent are dollars that came down from the feds that were in an act that passed. It was one of the last acts that President Obama signed back in, when it would have been last December. The dollars that I think it was $2 billion across the United States. And it was dollars that specifically targeted for opioid treatment and other initiatives and things like that. The dollars got separated out, came down to the state in a form that in the state of Michigan got $16 million for this. And again, all the dollars have to be used for opioid-based initiatives. And out of the $16 million, 1.3 million of it came down to us at our level. Now the dollars when they came down, they were very, they were earmarked funds. They were very much directed in terms of how we're supposed to spend those dollars. The state gave us the allocations and said, send us a response in 2 weeks in terms of how you're going to implement that. So that's how the whole thing came down. So we didn't have a lot of say. We didn't have a lot of planning time. But it's certainly an opportunity for us to impact on the opioid problem that continues to get worse and worse, not just in the United States, but in Macomb County especially. So we're one of the top counties in the state with number of opioid overdoses. So it's very appropriate for us to do that. There are very quickly, We'll do the Strengthening Families Iowa model, which is basically a parent and child intervention, family intervention, and it involves parents and kids in the same program. The target is actually the parents that are in MAT programs, Medicaid Assistance Treatment programs. And there's a training that's involved. It's 7 weeks, and they have the kids go in one track, the parents go in another track, and then they come together at the end. And it's an evidence-based model, and it's one that has been very successful before. In fact, we implemented this about 4 or 5 years ago on another requested for funding initiative that came out of the state. So the ones that's implementing that is Macomb Family Services. Will be implementing at least initially with Biomed Services. So those are the 2 agencies that will be involved. And I guess that's what I'll say about that. The other one then will be the Red Project Nope. This is basically an expansion of what we're currently doing, trying to get Narcan out to the community as much as possible. We control quite a bit of Narcan here, and we send it out to providers. We do it to law enforcement. We're starting to get more requests from agencies out there that want to be trained and they want to have it there because people are seeing the overdoses in the community. So this is what the Red Project Clinton County Counseling Center will be expanding their existing program that works with families to become. They're going to kind of be primarily. They'll be doing most of the trainings related to the Narcan. You have required trainings that go with that, and then they'll be targeting more groups and doing trainings out there, and we'll be continuing to provide the Narcan. Third one is a motivational interviewing in MAT programs. MAT is the emphasis on a lot of the initiatives that are coming down. They want to have more of that. It is evidence-based. We've talked about this before, I think. And so this is an opportunity. This piece, all we're doing is providing incentives for providers to send people for more concentrated training to be able to do the motivational interviewing. The motivational interviewing you use with people early in treatment. It helps keep people engaged in treatment and that sort of thing. So that one is doing that. What we're going to be doing is we're paying a per diem to programs for every staff member that attends the trainings and the follow-ups that go with that, so that they won't lose money by sending somebody to training, because if you have staff people out, they can't bill for services. So that's what this allows us to do. The state's doing all the training. They're coordinating all of that. Should take place after the first of the year, but that's basically what they're going to be doing. Project Assert is a recovery coaches, placing recovery coaches in the emergency rooms at both St. John's and in Henry Ford hospitals. What they will be doing is basically engaging with people that come in with an overdose that gets reversed, that come in. They're going to be trying to engage them into treatment, and identify other people that come into treatment, and then they're going to help them into our treatment system as part of that. It's already been started. We started that several months ago, and it's been very well received so far. Let's see what else. The medication-assisted treatment enhancements. This one is basically paying for pharmaceuticals that aren't covered under other plans, and a lot of those would be for people that aren't eligible for Medicaid or Healthy Michigan. It's the people that we would traditionally serve under our old block grant system, the federal block grant dollars that we've got. So we'll be buying those things that they couldn't get them otherwise. Also, we're looking at peer coaches. Peer coaches is real big through this process. It's almost every project that we're putting in, we're adding peer coaches. And for the purpose of peer coaches, CARE of Southeast Michigan, they're the ones that provide the coaches. They have been doing all the recovery coaches since about 2011. So this one also has that will be focused specifically on clients that are in MAT programs. let's see, what's else? And then there's some, we're also giving them more training, more dollars for transportation so clients could get back and forth to treatment. We just don't have enough money out there. There's not a good system out there, so we're going to be doing that. And then, I think, well, the last piece is the thing called mission. Now, this is something that came at the end of this after we already did our proposals, but the state suddenly said, okay, Oakland County, Macomb County, and Wayne County are going to participate in this project. And it's called the Mission Project, and it's supposedly another evidence-based project. But basically, the point of this project is to be able to help people that are in prison and are on their way back to the community. So what this whole project is to try and make that that transition back a better system, get people into treatment. Again, we're using recovery coaches, 2 recovery coaches, one for Huron Valley for the women's system, and another one is for I don't remember what the other one is. Detroit, whatever it is, and they will. And they're getting a recovery coach each for each client, and each one will have a case manager. So this one is, this is worth, it's, thank you very much to have that. But that one is interesting because that right now, that involves a lot of people, a lot of organizations, because it's not just us, and it involves the DOC. They're working out of the University of Massachusetts, was the producer of this thing. They've got 3 universities involved in this, and don't ask me what they're all doing. So it's really kind of a pilot project that has some potential, but so we're trying to make that one work and fit too. CARE, by the way, for recovery coaches, they started out with about 8 of them at the beginning when we first started doing this. And remember, we had the RFIs earlier this year that went through that we had 4 other initiatives that were there. They started out with 8 recovery coaches in their organizations. By the time they get through here at the end of this fiscal year, they will now have 21 recovery coaches. So they've been scrambling like crazy to try and find qualified people to do that. But it's going to be the strength of this, a lot of what we're doing here, I think. So I'm sorry, that was probably more than an overview, but.
No, that's all right. You had a lot to cover. We've got a couple questions, starting with Joan.
So they gave you all the money and you had to dole it out, right? Can you hear me?
Sort of.
So what do you have in Warren? Is it St. John's Macomb Hospital you work with?
I think it's St. John Macomb in Warren. I'm not sure. Is it?
It's on Hoover.
Okay. Yeah, then it is. Yeah, St. John Macomb is in Warren.
And what about this SHARE? SHAR.
Yeah, that's in Warren. They're residential, primarily correctional treatment facility.
That's still up and running.
Oh yeah, that's been up and running for a while.
Okay, I just wondered what locations in Warren you is there anything on Shaner, 12 Mile and Shaner?
No.
Okay.
You have some, like Sacred Heart was in Warren, but they moved. Remember, they were at 13 and a half, and what is it up there, 13 and a half, so much, but they're now in Madison Heights for the methadone program. And they ended up closing down their outpatient facility because they weren't getting enough business. Trying to think if there's anybody else. Thank you.
Yeah, 13 and Van Dyke, that's where shot.
Yeah. Mm-hmm. But there's nothing there now. It's SHARE, it's the 2 that we just talked about.
Yeah. Okay, thank you.
But
Thank you,
that
Mr.
doesn't, we still try and get as many services as we can in Warren because, that's one of our heavy density areas where we have a lot of issues.
Yeah, I know.
Okay.
Are you going to that program that they're having Saturday at
think I'm aware of
Helmich
it.
Park?
I think I just got something on that, but I didn't read it today.
It's Helmich Park where Linda Davis,
Oh,
Judge
okay.
Linda Davis will be there.
Okay. I'll look into it.
Okay, thank you. Thank you, Mr. Chair.
Who else?
Kathy.
Thank you, Mr. Chair. You had mentioned that there were coaches that were going to be at St. John and Henry Ford. I believe.
Yeah.
And why are those two selected and not others? Or is this just part of this program? You have coaches everywhere?
Well, we started with we approached them. We approached them. You know, you always have Beaumont out there, but Beaumont is really they're known for not being, not to be critical, but they're not as receptive to being able to do some of the initiatives that we had. St. John was selected because Eastwood is part of St. John, and we know the history that we have there, and they were more likely to go ahead and do that. Henry Ford Hospital was just was much more was receptive to do that. We're starting out this way, and it's really it hasn't been done. So we're trying to see how it works and see if it has an impact, and then we'll look at expanding out to the others. But we try to keep it in the county. Especially.
Right, so you're still this is still experimental, or
yeah,
whatever.
It is very much so.
All right, and then you also mentioned more toward the end of your presentation, coaches. There's all kinds of coaches for everything. Now, whose employees would those be?
That's CARE in Southeast Michigan. When we started with recovery coaches long ago, what seems like a long ago now, we did focus groups. And we had some focus groups that we met with local providers, and a large percentage of those people that were in the community or in the recovery community, and other interested people, and asked them, we were proposing to do this recovery coaching thing, and we asked them a number of issues of how we wanted to do it. And when we asked them, do you think we ought to do recovery coaches at programs, and we didn't have enough money at that point to say we're going to give them to each programs, or do you think we ought to have it in one central location so that they can follow the client whenever they go? And that group, that group unanimously said we think it should be centralized, and in fact they endorsed CARE, which is why CARE has been really they got it from the beginning. They started it up, and they continue. And they're very responsive. Whenever we ask them to do something, they're right there to do it. Now, that doesn't mean that we might not change that model as we go. Right now, it seems to be working pretty well. But there might be specific instances where we want to do it. Now, Sacred Heart, they've got somebody that they're paying for their own recovery coach, but they want it as part of their system, which is probably a good idea because you always had a hard time getting people to stay once they left detox to get down to residential, and then from residential down to outpatient. So, anyway, I'm sorry, I digress. Yeah.
Any other questions? All right, seeing none, I'll take a motion to receive and file.
So move.
Motion by Marilyn.
Support.
Support by Chris. All in favor signify by saying aye.
Aye.
All opposed? All right. Next is a request to approve MCOSA fiscal year 2018 budget revision, add OROSC STR allocations of $926,922.
Move to approve.
Oh, you can't do it at the same time. Motion from Joan, support from Susan. I know. Did you want to speak to this at all?
Well,
kind of did.
This is what we just talked about.
Perfect.
This is just putting in place in a budget. If we don't have it in a budget, we can't spend it. So, and this only represents next year's 2018. There was an additional amount, as you know, when you look through here, that covered in 2017. That's all I'd say.
Anybody have any questions? All right, seeing none, we have a motion and support. All in favor signify by saying aye.
Aye.
All opposed? All right, it's approved.
Thank you.
Thank you. Next, we have a receive and file review of MCCMH fiscal year 2016-2017 Internal Services Fund and Financial Status Report Analysis Executive Brief. John, did you want to speak on this?
Yeah, sure. It's certainly important that we talk about this for a few minutes. I've asked Cindy Mack, the CFO, to come up and give us an overview. What we put before you is what is standard and usual to you, the way we've been presenting the executive brief relative to our budget. It quickly takes a look at, previous year's revenues and expenditures, this year's revenues and expenditures, and and subsequent next year's revenues and expenditures. It's broken down by Medicaid. It's broken down by Healthy Michigan Plan. Cindy will go through that. It's also broken down by the combination of Medicaid and Healthy Michigan Plan. And then she's also going to talk about our general fund status as well. Before she starts in the board, as you've all been very aware for the last year, we've been under considerable financial stress that's played itself out across a number of different providers, consumers who have been harmed by our reduction in services, staff who have had to pick up double duty and added, challenge and to be able to administrate the organization, the lobbying efforts of the board, which have, been fruitful to us as well, too. But back in February 28th, we projected, as you recall, but I'm just going to remind you, back in February of 28th, when we closed out last year and we projected for fiscal year 16-17, which ends in 3 weeks, we projected a $9.8 million deficit on Medicaid. You all recall that. And that $9.8 million, we would wipe out down to zero all of our Medicaid dollars. And the $9.8 million was going to be borne by the Department of Health and Human Services as part of their responsibility in a shared risk management contract. That's where we started this year, $9.8 million in the hole. In April, we came to you and we had recovered much of those funds, and we had $340,000 to the positive. And what Cindy's going to show you here right now is, as of what we project in the next 3 weeks, that we will actually have $11.4 million back in our ISF. So that is about a $21 million turnaround in the last year, and it's been the collective efforts of the board and the administration and the community and the public and the consumers. But I think it's very important that we take time to take a look at that, where we're at now and where we go. It's a projection. We won't know definitively until February 28th how we closed out, but we've turned the ship by $20 million, and we have a substantial ISF and a strategy to move forward with the state when they ask us for that financial risk management strategy in November. So I'm going to turn that back over to Cindy.
Great. Thank you. My understanding is that you should have this at about page 30 in your documentation. The first page is, again, the regular format that I've been presenting, where it has the separated out by Medicaid and Healthy Michigan amounts. And what I'd like to focus on tonight, again, John gave the summary of where we've come from and where we are today. What I'd like to focus on in particular is fiscal year 16-17, and noting that this is based on our third quarter FSR that was submitted back in the end of August. And again, it's a projection, so it's the mixture of what we had as actuals and the rest of the budgeted up through 9/30 of this year. If you look at on the left-hand side of this, again, this is where I have Medicaid, and we started out our beginning ISF balance at about $15 million. We received revenue and projected revenue just for CMH alone comes in at roughly $149 million. We also report including substance abuse, and right there we have listed at just roughly $3.3 million. You'll see there's a line added that's referencing an abatement of ISF funds, which I will speak to later in this document. That's an amount of $10 million, which brings up the total revenue between all three sources to be $162.5 million. Our expenses that we're projecting to come in for CMH alone are $164.6 million. And then again, including in substance abuse at 3.3, our total projected expenses are $168 million. That's giving us a deficit of $5.4 million just for Medicaid alone. With the new amended contract, we're able to shift some funds between Medicaid and Healthy Michigan as far as covering the ISF. So in our last report, the third quarter FSR, we did choose to do that and transfer over, redirect some of our funds from the Healthy Michigan ISF to move into our Medicaid ISF. We did that making sure that our Healthy Michigan was still fully funded, and we took what we could to move over to Medicaid. That amount was $5.5 million. That brought us up to a surplus of $90,000 for our Medicaid. When all of those calculations come together, we have an updated ending ISF balance of $15.1 million. Then there's that line that I had referenced as far as the abatement of the ISF funds of the $10 million. That is a very, very complicated calculation to explain. It's basically something on the FSR from the state and how we are reporting that. And basically that abatement is something that we had to do in order to cover the Medicaid deficit. That Medicaid deficit originally would have been $15 million. But how it's reported on that FSR, and again, it's very complicated to see how it's on the form. It's just how it's fed into that form. We cannot show that much of a deficit. We can't really show a deficit. So we moved what we needed to, and by doing that abatement of the funds, it draws it out of the Medicaid ISF and moves it into revenue for that year. So by doing that, that's why you'll see it up above as showing as revenue. It's that abatement of funds. It drew down that Medicaid ISF. So when we take that into consideration, our ending ISF balance on Medicaid dollars was $5.1 million. After we completed our FSR, about a week later, we actually received notification from the state of that $5 million that after the efforts with the legislative actions and efforts by many, we did get that $5 million. So that was not reflected in the original ISF that we submitted in August. However, I did add it here on this to show what that will affect our bottom line. So taking in it, adding that $5 million, our actual ending ISF balance would be brought up to $10.1 million. And that's how we project to be starting off fiscal year 17-18. On the right side is the breakout of Healthy Michigan, similar format. There, again, we started out with a small ISF balance of $338,000 roughly. This year, we did come in with a carry forward from the last fiscal year of $7.8 million. For CMH alone, we had $10 million we're projecting, along with combining the substance abuse revenue of 6.8, giving us a total of $24.6 million in revenue for Healthy Michigan. Our projected expenses, CMH 11.9, substance abuse 6.2, for a total of 18.1. That gives us a surplus of $6.5 million. Here's where the redirect comes in. When we chose to cover and move over some of those Healthy Michigan funds, we did that redirect of the 5.5 to move over to the Medicaid ISF. So therefore, it deducted from our Healthy Michigan ISF, still leaving us an ISF, or a surplus, of $992,000. Adding that on to our beginning ISF balance, our ending Healthy Michigan ISF balance will be up to $1.2 million, we project.
Thank you very much.
Nice to present better news.
Yeah, much appreciated.
On the next page, actually, it's the combined. It's again rolling everything together, how if we put our Medicaid and our Healthy Michigan dollars together. Again, just showing us combined that our beginning ISF would be 15.4. Our total revenue, we're looking at 177.2. Total expenses, 186.2. Still showing that deficit of the 9 million. Then with all of the abatements and that $10 million that I discussed on the previous page, taking that all into consideration, adjusting our ISF balance, combined Healthy Michigan with Medicaid, we're looking at a 6.3 overall ISF balance. Then adding in that $5 million again brings us to that 11.3 million that we're expecting to close out the year.
Can you just make a brief comment too, Cindy? Sorry. Relative to what our proxy ISF is, we talked about that projected ISF that we should have in 3 weeks.
Yes, roughly about 12.3 million is what we're looking at as far as what we should be expecting. Again, 3 weeks, closing out the fiscal year.
So we're about $1 million shy.
Correct.
Okay, thanks.
All right.
I can
Sorry.
move on to general
Yep,
fund.
go ahead.
On the general fund, again, looking at fiscal year 16-17, we did come in with a carry forward from the previous fiscal year of $379,000. We're looking at a carry forward, the CMH revenue of 8.4, showing total revenue at 8.8 is our projection. We are looking at total expenses to be roughly 10.9 million, giving us a deficit going into the end of here this fiscal year of 2.1 million. We do have some redirects with some adjuster payments for our waiver programs, children's waiver, SED programs, roughly around close to 500,000. Taking that into consideration, we're actually looking at a total deficit of roughly 2.5 million in our general fund. Any questions?
Kathy, you had a question, right? Give it a shot.
The 5 million. Right now, how the contract is reading, we can actually use, it's interchangeable between the Healthy Michigan ISF and the Medicaid. We can use that in those funds to cover either of the ISFs. What we chose to do here is we had a fully funded ISF on the Healthy Michigan side where we were underfunded with our Medicaid. So we took what we could to keep our Healthy Michigan ISF still fully funded and took the remaining amount to help our Medicaid ISF.
Sorry, Mr. Chair. But we can't really spend those fund balances, but that's just so that we're in
Savings.
compliance with the contract to have that fund
Correct.
type of fund balance? Okay. And then what you just said now about the general fund, so we can't keep going at that pace, right?
Correct.
So what's projected, I guess directed to John, what's projected to make that healthy going forward?
The majority of those funds, the override was related to the Urgent Behavioral Health Care Center. And next on the agenda, Jim Lowe's is going to give us a strategy on how to fix that over expenditure.
Okay, thank you. Thank you, Mr. Chair.
Any other questions? Linda?
I also don't know how to ask it. For months, we were saying Lansing cut us too fast. We were approaching the legislature. We were asking for some way to recover that those terrible cuts, which were straight up effect. That's what they came from the clients, from services to clients. And so now this 11 million, or the 5 million, it makes it look fine, so we don't have any other way can't continue our argument for Lansing to give us those funds that they were still looking at. The additional, it was 7 million probably additional. And they came on the backs of the clients. That's not sitting well with me. I mean, sure, it's good news. It's a balanced budget, but at what cost?
If I can, speak to that, when you're facing, in the course of 2.5 years, $37 million, it's got to come from someplace. And so we put a number of irons in the fire to remediate what was going to be a revenue to an expense, challenge for us. And, we all sat here and knew administration and board alike, that we were going to continue aggressive utilization management practices against our consumers, and none of us felt comfortable with that. But it is what it is. And we also agreed that we were going to lobby the legislature to try to soften the rapidness of which we were going to have those funds reduced and services reduced to consumers. And we did that as well, too. So in retrospect, we've accomplished what we wanted to accomplish. We need to, this is a projection, we need to continue to engage in aggressive utilization management practices, because we're not out of the woods here. And that we need to continue to keep our PIHP financially sound. Because we talked before, if the PIHP isn't sound, nobody's going to be delivering the services around here. It'll be assigned over to somebody else. So I think we're on target. But there is no answer or undoing what we've done to the consumer. We're not going to turn around and now reauthorize some services. What we've done is we've aligned our services more closely approximated to what the department wanted us to do in the way of delivery of CLS services. And that's where we're at.
Any other questions? Brian?
John, correct me if I was wrong, but did not the legislators say in this budget period they're going to give us another $7 million next year?
That's my understanding. My understanding, we asked for 12.5 and we received the 5, and it's my understanding that Tom Leonard, the Speaker of the House, indicated, excuse me, that perhaps another 7.5 would be promised. And I can't make a case for that right now as a CEO that we go after $7.5 million when we're almost nearly to a balanced budget right now. I mean, we are mixing the Healthy Michigan funds in there, towards our ISF, but I think it would be a challenge to, go to the legislature and say we need another 12.5 or $7.5 million. We have to back out that, $6 million from Healthy Michigan Plan?
Correct.
We can't spend that. So there's still that deficit, but we would need to do some further analysis on how much we should ask the legislature for. I don't know if the $7.5 million is needed, the total 7.5.
Well, one aspect I would suggest you do is show the hit that the consumers are taking on this, on the programs that have been cut, and some of the programs we should highlight to which should be reinstated with that $7.5 million. Because they're also their constituents too.
And I've had some discussion with Henry Annas, and that's exactly what he's asked too. He's asked for evidence of hardship on our community, and I have forwarded him some emails that I've received recently, and particularly the one that I received from Lisa Lapine on her concern for the serious cuts that we've provided to our consumers. So I kept Lisa whole. It wasn't her name, but I did bounce the email to Henry Anna saying, here's some of the evidence, and maybe Lisa will speak to it later on, some of the hardship that's happening to our community. So that's what the House is looking for. The House is looking for, what is the hardship on our community? And so we can show evidence of that.
We can show evidence of that.
Yeah.
We can actually lay it right out, and here's what the cuts have been.
Sure.
Isn't there has there been another meeting scheduled with the legislator and the department?
I talked with Tom Renwick last Friday, and they have not positioned themselves yet to reschedule that meeting. They have concluded the discussion with TBD Solutions, who was the engagement manager on the CLS engagement they were getting into, but they're not positioned right now to reconvene the House or the Macomb delegation to report their findings yet. They're still in the process of writing that up.
Okay, then just a backup question to it. We have the documentation to show the hardship that's out there, that's prepared, that if that meeting does occur, we can show that to that meeting?
Sure, we'll be well positioned to be able to show statistically the number, the volume of community living support hours that we've cut. We can speak through evidences and testimonials of examples of, what we've done to the consumers, systematically. I think our group homes are about saturated. I don't think we have too many more placements for group homes. So a lot of consumers who were in CLS, living semi-independently, they're now in group homes. I don't think we have enough group homes. I think we almost have a waiting list, if I'm not mistaken, for group homes, and that's prohibited to have a waiting list. We'll be able to show through a white paper a number of compelling negative effects that's happened to our community and our consumers. Sure, we can do that easy enough.
Okay, thank you.
All right, I have Linda and then Lou.
John, I know that you and your staff did exactly what we expected you to do, was put us in a good financial position. So that, I'm not quibbling with that. But did I hear you correctly that you feel you would be hard pressed to ask for the $7.5 million now that we're in this financial situation? So does that mean that, I know you're doing some documentation for what Henry asked to build, whatever his case he's building, but does that mean that we are not pursuing that $7.5 million anymore?
Well, I think there's opportunity for further discussion here. The challenge is that this is the third quarter report that was submitted on August 31st. The final report to the department doesn't occur until February 28th. So that's like 5 months into next year already before we determine where we're at. But based on our utilization management practices and the way we're engaged right now, I think we may have a savings. And so my reservation of going to the legislature and asking for even more monies is that you've erased your projected risk where the department was going to pick up your $9.8 million. You've restored your internal services fund and then very well have some small amount of savings. Maybe not, but very well could. I mean, we need to pick up another $1 million. Anything over another $1 million, and then that's savings. So I have a hard time looking the legislature in the eye. Well, I take that back, $6 million we need to pick up in the next 3 months. And so if we did have savings, I think that would be pretty shameful of us to, ask them for additional monies when we actually corrected for the problem and also, had some savings. Will we be there? No. Will we have our internal services fund in our strategy cared for in November? Yeah, we will. So I think we need some further discussion. I don't think I'm fully ready to be able to, come to the board and say, how do we move, forward from here? I think we need to go back with IT and come to you with a plan and say, here's how close we're cutting the revenue to expense.
Lou?
John, as you know, I've always objected to the State Department's change allowing the shift from Healthy Michigan to the Medicaid side. I've described that as some exercise that the State Department wants to put into place to show a balanced budget overall that in reality does not exist. Now, this shift of Healthy Michigan to our ISF fund, stating it at approximately $11 million, if you'll forgive me, is almost a voodoo phantom number, because the ISF is meant to be utilized when you're in a negative bankrupt situation and you can't spend $6 million of that shift in the $11 million that you're showing. It's an exercise that the State Department is apparently trying to represent that isn't accurate in the reality of dollars. So if you say that you're hesitant to approach the legislature, I would suggest that the first step in the approach would be to point out to them the nonsense of the numbers based on a shift of $6 million that can never be utilized on the Medicaid side of the ledger, but the State Department will show the legislature overall for all of the PIHPs in the state of Michigan who might do that of how good the fund balance situation is, when in reality it is not. So, I hate to quote Republican presidents, but George H.W. once said it's voodoo economics, and it kind of is. I think it would be our responsibility to point out to the state, although the number is 11, that in reality, that is not the actual number that's available for service, based on the fact that that number is supported by a paper shift from Healthy Michigan that can never be utilized. And I think that should be the opening standard for the situation, because that's what the reality is. We don't have an 11 million ISF that can be utilized. What we have is an 11 million ISF on paper that is about $6 million short of that reality ultimately going into 17. So I think our responsibility for openers to our representatives in the House and in the Senate is perhaps a moment of truth. As we get closer to the end of the year, we might want to consider some sort of a briefing that indicates to them what the paper balances are and what the reality really is in relation to what our situation is. And I think that we should not hesitate to put that forward to our delegation initially and to the Speaker ultimately, because it will be his decision of whether we can pick up another 5 or 6 million out of that 7.5. We'll never get 7.5, just like we'll never get the 12.5, but if we're lucky, we might end up with 9 or 10, and I think we should pursue it, because that's the reality of where we are, John. We can't cut some of these services any further without having incredible crisis begin to happen. I think we've been lucky to have escaped so far as we have been, which is a tragedy for the people we serve. Ultimately, a tragedy beyond words. But I think you really ought to consider doing that.
If I can respond then to the chair, you make great points, and you're spot on. I appreciate where you're at. We have created a tragedy, and we have created some very serious health and safety issues for consumers. Some of our consumers have passed away and died as a result of our actions. They just haven't been on the front page of Macomb Daily yet. But your point is well taken, and I will work with the finance team and bring back a recommendation to the board on perhaps a method to proceed, because you're right, that $6 million is ISF, it's voodoo dollars sitting over there. We will continue to, through utilization management practices, cut services, and based on what we've been doing, we're going to pick up added dollars, but we won't realize that until, because this whole quarter isn't even reflected in this budget that we're providing for you. So it makes good sense to be able to pick up a strategy, bring the legislature back together, bring the board back together in unison, and then the legislature and say, well, okay, we've done our due diligence on our end, and you've helped us out too. Maybe we need $3 million or whatever. So I'll work on that and bring that back to the board. I'll work it with finance, and if you give me perhaps till the next board meeting in October, I'll bring you back a strategy. I think we have time still.
I think there's more than enough time, but we ought to have our thinking in a certain direction.
Okay.
I would be more comfortable if we made that shift.
Okay, I agree. I think you're correct.
Joan.
John, did I hear you right? Did you say that even if we had money, you wouldn't go back and help our consumers? Or did I misunderstand that?
We're not, if we have the dollars, we're not going to go back and change our direction on what we're practicing relative to utilization management, because we are charged with the responsibility to provide the required Medicaid services or the supplemental B3 services to everybody who needs those services in the county or in our geographic region based on the funding that we have available to us. And, you know, the reality is that we have lost $37 million. And we have gained none of that back. Even the $5 million that Cindy Mack talks about that's in the Internal Services Fund, that is strictly to be stuck in the Internal Services Fund. They won't let us spend that. So we don't have the $37 million to spend because we don't have it back, Joan. We don't have the money back.
I know, but if we get a little back, and you're talking, now we shouldn't go for the $7 million? I don't understand it. I mean, if we're going to get money back, then it should go back to the consumers.
Well, we would all agree with that. I'm trying to be as clear as I can because the further you get into it, the more technical it gets. I've tried, you know, at length for the last year to explain to the legislature what it means that we need to be fully funded in our Internal Services Fund in 3 weeks. And that's where we're at. But nobody really understands that. And even the liaison for the department, you know, I think I told you before, she says, you're going to take the money and put it in the bank? And I said, yep. And she slammed her book and pretty much reeled at that. But that's what we're doing. We're a risk-based contract, and versus being $10 million in debt, we actually have $10 million to cover our risk-based contract. And we can only carry forward 7.5%. So we need $12.3 million. If the legislature would give us 7.5, I'll be willing to meet with you privately about it too. But if the legislature gives us 12.5 and we only need 6, okay? Because Lou's point, we only need 6. That gives us our fully funded ISF, and it gives us savings. You actually have more money than what you need, and I think that's a bad spot to put.
So you're going to keep it instead of giving it back?
I just want to be whole. I don't want to be overfunded. I think that's a bad spot to put our legislature in, and what I think we should do is continue. I think we're on a good path, and we've been on a good path for the last year, that we've bitten off the lion's share of this, that we need to continue to look at where we're financially responsible and where we're not. So if we need to continue to reduce staff, if we need to look at our direct operating costs versus our contracted costs, that's a big deal. We need to get back around to the point where not only do we provide services to the consumers, but we need to be able to reimburse our providers. Our providers not being reimbursed at a competitive rate. We're still paying them 2015 rates. It's going to be 2018 in just a little bit. And
well,
so
then you'll give the provider something. You'll give somebody something.
As soon as I find the money to do so, yeah. I think it's still incumbent upon the administration and the board to come to you and tell you where you're paying for real expensive stuff and where you can get it cheaper. And I think that's the responsibility of the administration and the board to take a look at that. And I'll say it out loud again, because it's the elephant in the living room. Our direct operated costs for our staff are 2 to 6 times more expensive than it is to purchase it from a contracted provider. And we can save about $14 million there, but at some point in time, we need to move that direction. It makes no sense for me to hire Tracy out there, and her cost is $211 to deliver an outpatient therapy session. I can go over to Easter Seals and I can get it for $85.
Well, then how come we don't do that?
Good question.
Yeah. Thank you, Mr. Chair.
Kathy?
Thank you, Mr. Chair. I just want to follow up what Lou was saying. I think we need to continue. I concur with him. We need to continue the education process with the legislature, because while the numbers look good on paper, so we're technically in compliance with the contract, there could be a time when we run stuck because the ISF money, could be, we might need it on healthy Michigan, and it won't be there for that. So I think we need to keep working on that. And I was going to say something else, but I'll keep going because we do have a deadline here I will let you keep going because we have a time deadline here. Thank you. But we will follow up.
Thank you, Kathy. Brian?
Just to reiterate, John, the legislator don't understand the whole thing. but they are getting an understanding how this is affecting the community, and they're starting to understand which way the government's going on this, and they do realize that we have one of the top mental health systems in the nation, and they don't want to let that go. And saying that, I've received calls outside Macomb County from legislators on this issue, and they want to have discussion about it. So I'm just saying, let's don't close the door on this and have a program, have the numbers to show what programs have been cut, how they devastated the community, and show these legislators, you know what, this is where we're at, this is where we need to be a balanced budget, and I agree we need to be a balanced budget, but through your cuts, this is what's doing to the community that you represent. And a lot of them don't sit on the mental health board, their aides are in there, listen a little bit, there's more and more aides showing up to it. But if we can lay out the plan, here's where we're at, we got a balanced budget, but here's the cuts that had to take through the services, through the staff, through the ones we're doing, these are the cuts and the damage it's doing overall. Because I believe you know as well as I do, when they do go to privatization, all they do is cherry pick what they want. When they're making money, they take it, and everything else, they say, hey, the state, take it back over. And legislators are realizing that, so we need to continue having those discussions with them.
Okay, understood.
All right, I don't see any other questions or comments, so I'll need a motion to receive and file. Motion by Lou.
Support.
Support by Brian. All in favor signify by saying aye.
Aye.
All opposed? All right. Moving on to 7B, report on the operation of the MCCMH Urgent Behavioral Health Center. Jim?
Yes, thank you. In your packet, you will find a couple of documents, one kind of a bullet point summary of where we're at as far as the UBHC right now. Since June 1st, we have seen 169 consumers through the UBHC. As you might recall, in middle of June 12th to be specific, we made an adjustment to the model and moved from doing more intensive crisis intervention and kind of housing consumers while we tried to stabilize them in an effort to divert them from inpatient hospitalization. We changed the model from that to, excuse me, to doing more therapy, more case management, medication reviews through a bridge model where we are kind of acting as a bridge for services between hospital discharges and the ability of a consumer to access services through another provider. So if somebody's got a delay in getting somebody in for a psychiatric service, we can provide kind of an interim service in order to keep them from going back into the hospital. So that's one of the things that we're doing through there as well. We're also doing eligibility screenings, intake assessments, crisis assessment, and crisis intervention, but on a much briefer model, as opposed to trying to keep somebody up to 23 hours in an effort to stabilize. We're moving people through in a couple hours at the most in order to try to either divert them to another service that's more appropriate for them or to move them into community-based services. So we've adjusted the model. As you can see in the graphs that follow the bullets, we finally have seen some of our numbers catch up with the change in model for July, and all of the encounters and claims that end up being reported in these graphs are delayed by 30 days as they run through the system and are reported as encounters. Everything is always delayed 30 days. So we're finally starting to see those numbers catch up with the change in the model. As you can see, we had a fairly significant reduction in the program expense that was primarily on the GF expense side. We went from $211,998 in June to $93,000 in July. So we cut it by more than half on the GF side, and that was really the area that was putting a lot of strain on our system is the amount of dollars that from GF that we're going to support this program. So one of the efforts that we made was to try to reduce the GF dollars by seeing primarily Medicaid consumers, by not providing services that are not billable or not capturable on a Medicaid encounter. So we really kind of streamline that service to more represent what's available through the Medicaid benefit package. Minimal dollars right now supporting the UBHC. However, we will make some recommendations today with regard to how to further cut that, because I think we need to further continue to evolve the program as we move on. We're continuing to build volume. Referrals from the Access Center for face-to-face eligibility screening and intake. So if someone calls the Access Center, we're offering them the option to go to the UBHC to receive a face-to-face screening and a immediate intake and a more rapid access to services. That tends to help engagement with consumers. We're able to get people into services quicker and make sure that they're receiving the services faster, which should, in the longer run, reduce the inpatient hospitalization as well. Also, we have a agreement with Henry Ford Hospital for those hospital discharges, and Henry Ford is our biggest inpatient hospital provider. So we've come to an agreement with them. So for everybody that is being discharged from Henry Ford Hospital, Henry Ford has agreed to transport them to our urgent care center for a screening and intake at that point in time again, so we can engage them faster into services, hopefully move them right into services within a couple of days, if the service is available. If not, then we're providing those bridge services until they are able to get into the appropriate provider. Again, that's in an effort to reduce recidivism. People cycling back through the hospital when they are discharged, can't get in to see a psychiatrist for 6 weeks or more. People are cycling. They're not able to get their prescriptions filled. They don't have meds. They run out of meds, and they end up back in the hospital. This way we can provide them with services that carry them forward until they are able to see a provider and receive a new prescription, start therapy services, or whatever it's been recommended. Additional adjustments. We've been watching the traffic in UBHC and tracking the hours that consumers come in. I think last board meeting, I reported that we had minimal consumers coming through in the overnight hours. In the 11 weeks prior to developing the summary, we'd seen 11 consumers, so one per week in overnight hours. That just doesn't justify us in terms of efficiencies in trying to keep those hours available overnight. So as of October 1st, what we like to do is to reduce the hours from 24/7 to 8 a.m. to 9 p.m. on Monday through Saturday. That should allow consumers ample opportunity to come in during the week. However, if they're not available during the week, we still have those Saturday hours available all day that hopefully we can get consumers that need the services in. But we just aren't seeing the volume overnight to justify keeping the building open and the staff placed there to provide those services. One key point there is that the crisis center is operating out of that facility. They will continue to operate 24/7. There'll be no change to that. So that service will remain in place on a 24/7 basis. The other thing in terms of those particular hours, they tend to line up with the typical urgent care facility hours. There are very few urgent care facilities that are open, that aren't hospital-based, that are open 24 hours a day. So this tends to line up with people, what they know about urgent care facilities on the physical health side. So it's not inconsistent with the hours that those typically tend to operate. For the staff that are currently working overnight shifts, which is 2 peers and 2 access staff, they will be reassigned to daytime positions within the UBHC. That will allow us to increase our capacity for the daytime hours, which we're being strained a little bit right now, where we don't have enough staff to see everybody that's coming through the door. So this will bolster that staff and put them in a time slot where their services can be more readily used by the community. The demand we have right now does support that additional staff being assigned there. If at some point in time we do experience a lessening of demand, we'll look at reassigning those or some staff from the UBHC daytime hours to other facilities. No one will lose a position because of the change in hours and change in model. We are also having administrative meetings. We meet every Friday morning to talk about the numbers that are of consumers that are being seen at UBHC, what they're coming in for, the services that are being referred to, the length of time it takes them to get into those services, so therefore the kind of bridge services that we're providing, hospital discharge rates, hospital recidivism rates. So we're looking at all of that on a regular basis in an effort to continually make this more efficient and streamline the program to the extent we can to still provide the services that the community needs and wants, but to do it in a most cost-effective manner. Okay.
Thank you, Jim. I just want to say really quickly, I've only been on the board for about 6 months, and this was one of the first graphs that I saw, and I almost fell out of my chair at the dollar amount compared to the services provided. So I want to thank you and John and the rest of the team for working to, innovate and right the ship a little bit, because I was floored by this. So it's heading in the right direction. So
Yes,
thank you,
definitely
Jim.
going in the right direction.
Does anybody have any questions? Linda?
I have two questions. Thanks, Jim, for the report. And the first question kind of goes back to the general funds that have, really, we have this deficit mostly because of UBHC. My question to John is, how do we recover $2 million? What is this? Sorry to go back to the other document, but we went real fast through that. What is this thing called? Redirect from local fund balance to cover deficit that the UBH created.
We have some of our larger fund pools are the Medicaid, the state plan, the B3 service Medicaid dollars that we get in, the Healthy Michigan dollars that we get in, the general fund dollars. We also have opportunity to save dollars, in what's referred to as an unrestricted account. It's been there for 20 years or more. And that amount of money varies from time to time on how we're able to save monies. They're not GF, they're not Medicaid, they're not Healthy Michigan, they're in an unrestricted fund. So we have around $5 million in unrestricted funds, $4 million in unrestricted funds. And so had we not had those dollars, we would have to go to the county and ask them, to bail us out of the GF problem. So we're going to deplete. We're going to, based on our GF overrun, we will take those monies out of the unrestricted account, and I'll leave it just a little bit under, my Cindy Mack, CFO, tells me a little bit under $2 million in unrestricted funds still. I take responsibility for the UBHC. When I brought that before the board, I really believe and still believe someday it's going to have community benefit. I was willing to throw $1 million at it of general fund dollars until it took root. And it's costing us, more than double that, and it's just not taking root. And I take responsibility for that. That being said, we will not have a deficit. We will not go to the board, but we can't continue our current practices. We have to make our programs stand on their own on the value that the Medicaid dollars will support to operate the programs.
But it's being bailed out by that.
Correct.
Local fund balance that
Right.
could have been used for something else. And then my other question is, does the PIHP contract or something that we do with state office a responsibility for us to have a 24/7 operation in the county? I hear the crisis center is going to continue, and I'm glad of that. And that's not a telephone line. That's the real people, the volunteers and everybody?
It's telephonic, but it's staffed by volunteers and paid staff, yes.
But 24/7.
But 24/7.
So don't we have some? I thought in this 2017, every mental health has to have a 24/7 component.
We're obligated to have a 24/7, 365 pre-admission screening and evaluation department. Whether we direct operate that or contract out, we're required to have that. Our current face-to-face emergency psychiatric screening, EPE, or emergency psychiatric evaluation, is still in place with Henry Ford Hospital. So they're there 24 hours. You know, any one of our consumers can go to an emergency room, and the critical component is the pre-admission screening department, and we've always retained those responsibilities. Our access center does pre-admission screening. So someone goes to Traverse City, they go to Cherry Festival, they get sick in Traverse City, they call us. I mean, it's well known throughout the whole state who calls who when. They call us, and we have 3 hours to render disposition on that consumer, and determine whether we're going to admit to a psychiatric hospital, where we're going to admit, or if we're going to divert, how we're going to divert. And so we do have that in place. We have quite a few 24/7 programs going, but our access center has sole charge of pre-admission screening.
Thanks.
Susan.
Thank you. So I'm very happy to see this turned around. Thank you very much. I'm happy with some of the changes that you've made. I'm going to be curious to see, you know, you spoke about the next steps that you're taking to make sure that we're, you know, kind of delivering value for the money that's being expended, because, you know, I'm hearing things like, you know, things are being diverted from the access center, I think you said access center, that would have normally been handled there, being handled now at the UBHC, and that, you know, you're getting kind of finding a new, fulfilling a new need of referrals from the hospital upon discharge and things like that. So I'll be curious to see what that new source of revenue is having in terms of the results that we're getting, right? Because it's not just about making the UBHC financially sound. I mean, we want to make sure that it's delivering a result. It's not just about making the numbers right. We want to make sure that it's actually doing what it was intended to do. So I want to make sure that we don't lose sight of that.
And really, the goal is very, very similar to what we started the UBHC for, is to try to keep people out of inpatient hospital. So
Right.
we're still operating, you know, under the motto of we'll divert if we can. We're also addressing the back door, where somebody comes out, making sure that they get into services so they don't cycle right back in again, which we do have a population that does that.
Right. And I think we have always done that, right? I mean, we've always done that. We've just done it elsewhere in our system, not in a UBHC. And my question is does the creation of a UBHC and the expenditure for that achieve higher results? That's the measure that I want to see. What did it look like before? Now we've added this center, and we're trying to figure out how much, you know, that costs us, and trying to level that out, and then trying to see what the measures are coming on the outside to say, are we reducing recidivism? Are we doing, you know, that's where really we're going to decide whether this effort is worth it.
Yes, absolutely. And the next KPI report is due at the end of this month, where we will see a measure of that recidivism, hopefully with the change in the model that will reflect a reduction in that recidivism. You know, our KPIs, we've had recidivism for many, many years as a indicator. And we've always been at the high end of that, you know, right below or right around the performance threshold. And this should reduce that significantly. So I'm anxious to see those numbers as well. And that will obviously be an evaluation point for this program. Is it doing what it's intended to do?
Okay, thank you.
Marilyn?
Yeah, I have a question. When the people come to the UBHC and they get there, and then they've had their evaluation, and you say, okay, you need to go to, say, Henry Ford, a 19-mile road to be evaluated. How are they supposed to get there? Do they provide their own transport? Do you call an ambulance? If somebody dumps them off or brings them, are they expected to drive them?
Right. It depends on the circumstance. I mean, it can run the gamut in terms of if somebody's coming with someone and they have transportation available. They can be taken by a family member or a friend. We can also access ambulance services to get them there.
And then are they always transported to the 19-mile facility first to check out physical before they're then transported to the psychiatric? I recently had an experience with this. And the person went to UBHC, went to the 19-mile facility where they spent a great deal of time having physical evaluation, and was then transported and moved over to the psychiatric hospital in Mount Clemens. Is that the typical path for all this?
Right, they have to receive a medical clearance before they can be admitted, and that typically, I believe, does happen at the 19-mile facility. They don't necessarily have to go to Henry Ford. Sometimes it's dependent on where there's a bed available.
Okay, all right.
Lou and then Chris.
Thank you. Given the present usage, I think that's occurring at the UBHC, I think these adjustments are prudent and make sense. Personally, I've been surprised at what I might describe as the slow start at the UBHC. I think all of our expectations were higher. I'm beginning to believe that the UBHC is the county's best kept secret. It occurs to me that radio stations and TV stations are obliged to make personal promotions, announcements in order to maintain their federal license. I'm thinking that staff should put together a 15 or a 30-second situation, and we should approach some radio stations on the basis of, do you know that the best kept secret in Macomb County is the UBHC if you have a mental health or a physically disabling concern? And perhaps even attempt to expand that with the TV stations. The TV stations usually do it at 3:30 in the morning, but a lot of people watch TV at 3:30 in the morning, and these won't cost us anything. I think if we put the dialogue together, we might increase the PR and we might get some traction, because the best kept secret can't continue forever on a budgetary situation. And I'm thinking that we need to get out there in a very proactive way and enroll the radio stations particularly. That would be easier because that's a written situation that they could do in 15 or 30 seconds if we time it. And something for the TV might be a little more complicated, but we ought to look at that, because I think people just don't know that it's available. And I think we need to do something about that.
We have had some efforts in that area. In fact, we had an article in Our Magazine. Macomb Daily did a story. We had two of our staff interviewed for a spot that aired on radio. So we've had exposure. We have, over the last, say, 6 weeks, held off a little bit on expanding that and trying to drive home a message to look to see what we were going to need to do in terms of adjustment to the model. And one of the things in particular was the hours. We were watching that trend in terms of when we were having people in, because we hated to go out there and say, we got a 24/7 hour program that you can access, if in fact we felt like we were going to have to cut the hours in order to be more efficient. And so I just spoke with Kevin, a gentleman who works in our office, to help us put some of these materials together with him yesterday, let him know where we're at with the hours, and we're going to reintroduce a campaign to get word out on kind of the new model of the UBHC. We did have billboards up. In fact, it was just until this week we had a 24/7 billboard up for UBHC at 12 in Groesbeck. So we had to call them and say, and it actually went a couple of months beyond our contract, and we had to call them and say, hey, we're adjusting our hours. That billboard needs to come down now because we're not going to be 24/7 anymore.
Thanks, Jim. Chris and then Joan.
Actually, most of my question was answered. It was regarding the marketing of the program, because obviously we got a volume problem here, and I know that the people are out there because they end up in the ER. So it's not the fact that there's not people that can use these services; it's the fact that there's a lack of the connection of these people in need to the services. So maybe included in the marketing strategy would be approaching the the medical community, I mean, I think it'd be prudent to engage the, providers, because I think there's probably quite a few physicians and mid-level providers aren't aware of these services, and it'd be something that they could direct people to kind of prevent them from having to go to the hospital.
Right. Agreed.
Joan?
Thank you, Mr. Chair. I think we discussed this before, but you've got a lot of people that need these services from Warren, but they're not about to drive them all the way out here to drop them off. It's location. That's what's wrong. Because you keep saying, or our substance abuse director kept saying, there's a lot of people in Warren, the lower part, not only Warren, you got Roosevelt and East Point and all that. But they're not about to run all the way out here to drop them off. So if you want to advertise, you better start advertising above 16 Mile Road or 15.
Selena?
Jim, have you looked at, and maybe you are doing this at the UBHC, is that often the patients will come into the emergency room, but they don't need to go inpatient. However, we're not comfortable and I'm speaking on the hospital side, they're not comfortable discharging them back into the community in the dark with no resources to go to. Will you guys be able to offer something in the morning where if we kept them through the night but then brought them straight to you in the morning, where you could provide that, that one-to-one, that face-to-face counseling? Because a lot of times they end up getting agitated because we don't really know where we're going to, what we're going to do with them. Then they end up going inpatient, where if we had a plan or some type of an agreement with you guys that you would then provide the first 3 hours of the morning for these crisis situations that need that one-to-one as a diversion.
Well, we would certainly be available to do an eligibility screen and an intake with somebody, immediately post-hospitalization. And one of the things that we want to do more of, and as part of this campaign, is to use our crisis residential services as a step down from inpatient hospitalization, which might provide a nice transition from that hospital unit back into the community via the crisis residential program, and then into ongoing services in the community. So we'd be more than willing to do that.
Okay, because I'm looking more coming in from the emergency room, and not necessarily as a step down from an inpatient unit. The patients don't need to go inpatient, but they really can't go into the community with no resources. So, I know that I've spoken to a couple psychiatrists that would offer, that 1 hour, that an hour in the morning at 7 a.m., where we keep them through the night, we keep them in a safe setting, and then, he would see them because we're not getting the authorization to put them inpatient.
Right. Well, certainly that would be a service that, we're obviously willing to provide services that the community needs and providers need. So we can, I'll raise that at our meeting on Friday morning, and see if there is, because we're moving away from that, we'll hold somebody for X number of hours until they stabilize, that we were trying to do previously. So I'm a little bit concerned about, okay, if we've got somebody coming from the ER that thought they needed inpatient admission, but maybe they really don't, okay, once they come to us, what's the next step? And we need to have an exit strategy there. So we can certainly discuss that with our team, and then maybe I could have someone reach out to you and talk about.
I think that would be a good conversation to have, because a lot of times the patients just need a face-to-face or a therapy or a counseling or help connect them to something besides a phone call. Okay.
All right, seeing no other questions or comments, need a motion to receive and file the report. Motion by Lou. Support by Kathy. All in favor signify by saying aye.
Aye.
All opposed? All right. Next item is a resolution for CMH employee retirement. Paul Militello. Need a motion to... What's that, Joan?
Support.
We'll give a motion by Joan and support by Susan. Any discussion? All right, all in favor signify by saying aye.
Aye.
All opposed? All right, passes. Next is other agenda items. John?
In front of you is the notice for the Metro Region dinner meeting. I think you've all been apprised the fact that the date was moved per the request of the Detroit Wayne, who is hosting. The dinner meeting is September 28th at 6 o'clock, Detroit Golf Club. And if you would kindly let Barb know so she can register those board members and interested staff who want to participate.
And I just want to mention real briefly before Joan, I want to thank Lisa for giving me a tour of the Macomb Arc. I've lived in Chesterfield my whole life. I've never had a tour, and she was gracious enough to give me a tour. Was that 2 weeks ago now almost? So thank you for that, Lisa. Joan?
We have a recipient rights meeting the 28th of September at
18th.
Oh, I'm sorry, the 18th. I'm a week ahead of myself. And that'll be at the administration building. So I hope to see at least 7 of us commissioners there. Thank you.
Thank you, Joan. Lou?
A comment on the new look agenda. It is a new look, but subject to correction. When we see the Macomb County, Michigan seal, we generally see the executive's name under it. Perhaps we ought to think about that before he notices it.
Duly noted, Lou.
Just a thought. If we're proactive, it might save a few bumps in the road. But just a thought, as I say.
Thank you, Lou. Anybody else with any other business? All right, seeing none, we'll move to hearing of the public. 5 minutes for anybody wishing to address us. We can listen, but we can't respond.
Good evening, Lisa Lapine, Arca Macomb, 44050 Gratiot, Clinton Township, Michigan, 48036. I apologize for my casualness. I am on vacation. And when I learned you were talking budget, I just could not stay away. This last year has been incredibly difficult. Kudos to the team at CMH for pulling it together and getting you as far as they've gotten you. But it wasn't without a lot of challenge to a lot of different folks. And it would be remiss of me not to point out to consumers and providers, they're hurting, all of them. I can't talk to you people without crying. There's a real problem with all of you. It's not me. There are 3 things that I like to address with this. And last year, with the challenges that we've had, we've created a plan and we've done a lot of changes and we've made a lot of massive change to folks. And now we can stop and we can think. And maybe we can do it with a little different style than what we've done in the last year. And I would specifically encourage Community Mental Health Administration to revisit their level of care document. Specifically, I'd like you to look at the steps. Level 1, level 2, level 3, level 4. You got a level 3 and a level 4. You either can live in a group home or you can get a recommended number of hours. Of course, adjusted to person-centered planning, but the maximum number of hours for the week is 55. There are 168 hours in a week for a person with a developmental disability who needs staffing support, who isn't going to survive outside of a group home. Sometimes 55 doesn't cut it. And I understand that it is a guide. I understand. But there needs to be a level within there that allows people to choose to live in this community outside of a group home with staffing when they're home every hour. There's no law against it. There truly is no law against it. CLS can be provided when people are sleeping. It's been litigated. People do have adult home help services available. Those can be used. People shouldn't have to choose to either live in a group home or go without staffing support in order to live their lives. We're really missing a group right there. Our group homes are full. They're full of people who didn't choose to go there, but had to in order to get the staffing support that they felt was necessary to keep them safe. We also got a lot of people living out there without staffing support who are at risk. And Brian, I'd love to share some of the numbers that I have, because I got quite a few of people who I'm kind of waiting on the balance to see if they're gonna live or die. And I don't say that casually. I say that intentionally. Those cuts that we made to CLS were secondary cuts to providers.
Many people who are simply CLS providers are trying to figure out how to stay in business with the added issue of not being able to pay a living wage. Now we can't even hire folks to cover the staff that we need to support folks. And without hours to support the people that we have, we're going broke. In addition, we've come up with this per diem structure that I can't wrap my head around, and I think I'm pretty smart. But we've got this per diem structure that says it's based on person's utilization, and you can use in between 3 to 5 hours, or 7 to 9 hours, or 10 to 12 hours, or 14 to 16 hours. And we have to write a person-centered plan that's medically necessary, that meets that individual's needs, but we can give them a range. But we won't consider looking at utilization. Instead, we'll say, hey, we'll give you this range of 20 to 24. Maybe you need 20, or maybe you'll use 24. How can you do maybe if it's clinically necessary? Can't wrap my head around it, but we're using it. And then finally, vocational providers came to you guys in partnership, and we said, hey, we can save you some money. Look at contracting directly with us, take MRC out of the picture, and that happened. But then rates were adjusted. And we said, those rates aren't going to work for us, guys. They're hurting us. And CMH said, we hear you, we hear you, hear you. But we've gotten no relief. At the end of the day, we've had a horrible, awful, God-blessed year. I have 7 hearings next week when I come back for people whose services were cut. So they haven't slowed down. And I'm not losing every one of them anymore. Hate to tell you, I'm winning some. At the end of the day, now's the time to revamp, remodel, make a plan, partner. Please hear us. Please hear your providers saying, hey, there are better ways to do this. And it doesn't have to be coming from me or from Owen or from Lonnie or from Carmen, the 4 that are sitting here tonight. It can come from anybody. But what we're proposing to make plans and changes to the county and to help you with, they happen throughout the state. And we're willing to partner and to make this happen, but we can't do it at the rates that we're doing it. We just can't. So as we go forward, I'm thankful that you guys were able to pull yourself up by the bootstraps, figure out the financial budget. But I'm going to say we can do better by the people we serve by simply looking at some of the things that we've done and adjusting them. There is a third group of people that have been hurt by the challenges that we've had in the last year, and that's your very own sport coordinators. They have gotten the bejesus kicked out of them from curb to center. They write the plan, and they're told constantly and continuously their plans are not sufficient to meet the individual's needs. And they go to hearing and they hear how bad they are. Let's take this time to revisit some of these things to improve the model of delivery that we have in this county so that we can improve the lives of the people we serve, improve the lives of the people that work for you, improve the lives of the providers that contract for you, and move forward understanding. I heard you. What I heard you say was not that we wouldn't give the money back, but it needs to be done in a medically necessary, appropriate way based on utilization management and on individual needs. Let's dedicate ourselves to that purpose and in a way that reminds us that the people that we serve are human beings and that we have the home and community-based waiver breathing down our neck. Because we have an opportunity now. We've saved the ship. We've all taken hits. Now let's figure out how to do it better than we've been doing it. Thank you.
Thank you, Lisa. Anybody else from the public wishing to address this body? Anybody else? All right, seeing none, we'll close the hearing of the public, and I will take a motion for adjournment.
So move.
Motion by Joan, support by Brian. All in favor signify by saying aye.
Aye.
All opposed? All right, we are done. Thank you, everybody.